Yu Wen Lee is a 28-year-old woman who presents for a family planning visit. Yu Wen was born in the United States to parents who immigrated to the U.S. from Taiwan 30 years ago. She has no significant medical history. Hello, Miss Lee. I understand you're interested in becoming pregnant.
Yes, my husband and I have been talking about it for a while, and we think it's time. My parents will be so excited.
Have you told them yet?
Not yet, no. I wanted to talk to you first. I wanted to know what to expect before we started telling people.
Okay, well, this is a good place to start. There are a few tests we can consider, and we'll talk about your lifestyle habits and your health history.
Okay.
I see in your records that you received most of the recommended vaccines, and you were born in the U.S.?
Yes, my parents are from Taiwan, but they came to the U.S. before I was born.
Any family history of illness?
I don't think so. My dad takes medication for cholesterol, but he and mom are fine. And I'm an only child. I did have an aunt who died a couple years ago in Taiwan. They said it was liver cancer, but I didn't know her very well.
Okay, let me ask, have you ever heard of hepatitis B?
I've heard of hepatitis.
Well, hepatitis B is a virus. It can cause liver disease and liver cancer if it's not treated. The reason I ask is that hepatitis B is common in certain regions of the world. Taiwan is one of those areas.
Do you think that's what my aunt had?
Well, it's possible, but I couldn't say for sure. We should definitely screen you for hepatitis B since your parents were born in Taiwan. National guidelines recommend a one-time screening of people born in countries with a high amount of hepatitis B, and that extends to children born in the U.S. to parents from those countries.
Oh, really? How's it transmitted? Can it harm my baby?
It can be transmitted through body fluids like blood or semen. For example, it can be transmitted through sexual contacts or injection drug use, and it can also be transmitted from mother to child during pregnancy or birth.
No, my mom and dad met in high school. There's no way they got a sexually transmitted disease. And I married my first serious boyfriend. No one in my family has ever used drugs. This can't apply to us.
Okay, let's just go ahead with the rest of the exam for now. Okay.
Thank you everyone for joining us today for Module 2 of ECHO Hep B. We're very excited that ASLD just finished yesterday. This is American Association for Study of Liver Disease, and Hep B again has become one of the prime projects of research because we now want to eradicate hepatitis B. And again, part of the program, what ECHO Hep B is also targeting is to increase the screening and treatment for patients who are infected with hepatitis B. So last week, we actually covered areas that were highly prevalent for hepatitis B, and we also wanted to, we discussed about the barriers and how we can overcome these culture and system-based barriers from patient standpoint, as well as from clinician standpoint. So now we are moving into the next module, which is to demonstrate proficiency of hepatitis B serology and interpretation. And again, this is one of the areas where we commonly find that there is a little bit of understanding that needs to happen. Even in my own training program with the GI fellows and residency, you often see that some of the serologies and interpretations can still lack the standardization. So going ahead.
And while you get that set up, I think now is a good time for us to launch our pre-lecture polling questions. First question is, how confident are you in interpreting HBV serology? Not confident, slightly confident, moderately confident, or highly confident? I'll give you just a couple more seconds. Okay, our second question. I correctly distinguish between HBV immune, protected, or infected status based on serology. Never, rarely, sometimes, often, or always. Okay. And our last question. Which of the following is a marker of chronic hepatitis B viral infection? Presence of hepatitis B surface antigen, high level of serum HBV DNA, presence of serum hepatitis B surface antibodies, or presence of hepatitis B core antigens? We'll give you a little time on that one. Just a few more seconds. Okay. Thank you all for answering those polling questions. And Ram, feel free to share your slides.
Okay. So I'm glad actually most of you answered all those questions correctly. So before we go into today's presentation, anyone wants to share any cases today to the group, especially those who answered all the things correctly? Okay. Well, the platform for Echo Hepatitis B is to basically share information, share our knowledge, and make everyone in the group more proficient, so we understand the different presentations of chronic hepatitis B and how we can help our patients based on all these variety of presentations. So for me to kind of have a segue for this talk, we used Yuwen. She's our 28-year-old woman who was born in the United States. So again, United States not being a area of high prevalence, but she's born to parents who actually hail from Taiwan. And Taiwan is an area which has more than 8% prevalence of hepatitis B. So that is an endemic area in the world. So even if she was born in the United States, if the parents are from a highly endemic area, this is a patient, this is an individual who needs to be screened for hepatitis B. So as you saw, she went and talked to her primary care physician to discuss family planning. And although there was an initial conversation about whether this is necessary or not, we finally found a context because she's planning to give birth, that's number one, and she has family history of HCC. So again, putting it in the context, she would agree to undergo the screening for hepatitis B. The next question that really comes when patients come to my office is they come with one or two sets of labs. And again, most of the time it could also include something that is out of the blue, like a hepatitis B E antigen or an E antibody. So to kind of do the hepatology, the serology for hepatitis B one-to-one, the three most important tests when you want to screen for a patient for hepatitis B are hepatitis B core antibody, hepatitis B surface antigen, and hepatitis B surface antibody. Okay? We'll start with the hepatitis B surface antigen because this is a marker of active infection. Now we know that hepatitis B surface antigen, the activity of the virus within the liver can remain high or low, and surface antigen is a pretty good marker of the viral activity within the liver. If you want to diagnose a patient with chronic hepatitis B, again, the presence of surface antigen for more than 6 months itself is indicative of chronic hepatitis B. We don't need virus, we don't need anything else. Just the presence of surface antigen for more than 6 months would qualify the definition for chronic hepatitis B. Now, when you look for hepatitis B surface antibody, this is an antibody to hepatitis B surface antigen. So this is a marker of immunity to hepatitis B. And again, if you vaccinate a patient when the patient is newborn, or a susceptible patient without core antibody and surface antigen, you would expect that most of these patients would develop surface antibody as a result of the vaccination. There are different vaccines that are available now for hepatitis B. The age-old vaccine that was available was a component vaccine on surface antigen. There is now a 2-step or a 2-series vaccination, which is pretty potent. It's called HEPLISAV. And in the recent AASLD that we came from, there is now a trivalent vaccine, which is even more immunogenic, and you could basically get an antibody response with 2 shots. The other screening test that we want to do is hepatitis B core antibody. So this is the presence of IgG to hepatitis B core antigen. And we do not have serum tests for core antigen. We only have a commercial test that would test for core antibody. So again, in one of the polling questions, was one of the options. And those who checked on it, there is no core antigen that is available. So we need to make sure that core antibody is one of the screening tests. And it is a reliable marker of previous infection, although there is a very small 10 to 15% chance that it could be a false positive. But majority of the time, it tells us whether the patient was previously exposed. In certain cases, especially those who present with an acute hepatitis flare, or in the healthcare setting, if someone gets exposed to blood or body fluids from a patient with hepatitis B, you can anticipate that the IgM for the core antigen would go up. But again, we use that in very sparing situations. So this is step 2 of hepatitis B serology. So you wouldn't normally check for e antigen or e antibody or DNA unless the patient is positive for hepatitis B surface antigen. If the patient has surface antigen positivity, then is your next step to check for e antigen. E antigen typically tells us whether the patient has a wild type virus or a mutant virus. Again, this is not really set in stone. Most of the time, when the patient has e antigen, this is associated with very high viral load, and very high viral load actually indicates that this is a marker of high infectivity or contagiousness. So again, those with very high levels of e antigen, those with very high levels of DNA would typically have e antigen positive disease. Now, during the course of treatment or during the course of natural history, a patient who was initially e antigen positive can develop e antibody. There are a very small proportion of patients, especially from the Asian population, that they can actually start with an e antigen negative disease. And if they start with the antigen negative disease, most of the time they would have antibody to the hepatitis B e antigen. So that's the e antibody. This again is typically associated with pre-core or basal core promoter mutation, but again, this is not always the case, but this is what you see in your association. And typically, if you don't have e antigen, the viral loads tend to be a little bit on the lower side of the spectrum, And that is the reason why we have different thresholds to treat hepatitis B when they have e antigen positive disease or e antigen negative disease. Moving on to hepatitis B DNA, now this is the sole marker of active viral replication. So again, this tells us that any positive virus means the virus is actively multiplying and actively replicating. Now, things that we don't have in this slide, again, but for the purposes of academic reasons, you can always test for hepatitis B genotype, okay? So people who hail from the Asian countries typically have either genotype B or C. And classic teaching, again, in the past was genotype C is typically associated with higher rates of cirrhosis and higher rates of cancer, okay? And it is also a common norm that if you see a patient who is not an Asian, the chances of that patient having genotype A is quite high. So again, you typically don't expect a patient from Asian countries to have genotype A. And a therapeutic implication of this is genotype A typically responds very well to interferon. So again, there are some nuances to know about hepatitis B panel. Again, another thing that you won't see on this slide, again, to keep it only pertinent to hepatitis B, but it is important to know, is the presence of delta. So again, hepatitis delta, it is a defective virus, and if you're seeing low levels of hepatitis B DNA, the chances are this patient could have hepatitis B delta on top, and if the patients have delta positive infection, their viral loads tend to be on the lower side. So again, a one-time check can be done, especially if it raises the threshold that you see a patient with elevated LFTs, but the DNA is on the lower side. So to interpret the serologies, again, the first scenario in the first row is all three parameters of step one, which is core antibody, surface antigen, and surface antibody. All three are negative. So this is a situation where the patient is susceptible to hepatitis B, and like our patient who is planning to get pregnant, or any of the patients that you encounter in your clinics who either had a sexually transmitted infection, who is an injection drug user, or sexually active, multiple partners, those who are at risk for parenteral infection, this is your opportunity to actually vaccinate them. The ACIP, this is the American College for Immune Prophylaxis, they actually recommend that susceptible individuals should universally be vaccinated for hepatitis B. The second row presents a scenario where the patient has a hepatitis B core antibody that is positive and hepatitis B surface antibody that is positive. But remember, surface antigen is negative. So this is a patient where you can basically look at the panel, and because the core antibody is positive, the chances are this patient was exposed to hepatitis B, and the patient developed an immunity or antibody as a part of the natural history of infection. This is the typical case of serologies you would expect if a patient gets exposed as an adult. Remember, as an adult, once your immunity is competent, even though you get exposed to hepatitis B, 90%, 80 to 90% of the time, you can eradicate the virus and you can get immune. The third row of this slide tells you that the surface antigen is negative, core antibody is negative, and only surface antibody is positive. Now, because the core antibody is negative, that's your giveaway clue that this patient is immune to hepatitis B vaccination. So if you identify a susceptible patient like in row one and you vaccinate them, I think you did a great job, and the patient will be presented as the person in row C or row 3. Now getting into a little bit more complex situations. So the first row tells you that the patient's surface antigen is positive, core antibody is positive, and surface antibody is negative. Now, because of, you have to put it in the context that this patient typically has very high levels of liver enzymes. Patient typically can be jaundiced. And that is a scenario where if you want to figure out whether this is an acute infection or a chronic infection, you test for IgM. And if IgM core antibody is also positive, majority of the times this would tell you that the patient is acutely infected. Again, not to hang your coat on this, but if a small percentage of an acute flare in someone who has chronic infection can also have IgM to hepatitis B core antibody. But again, remember, you have to use this in the right context. You don't have to test for IgM unless you actually see very high levels of liver enzymes and you correlate with the clinical history. The middle row in this slide tells you about hepatitis B surface antigen, which is positive. Total hepatitis B core antibody is positive, but IgM is negative. And again, lo and behold, surface antibody is negative. So this is the classic definition of chronic infection. So again, all you need is surface antigen positive for more than 6 months. And since the core antibody is also positive, this is a patient who has been chronically infected. The last scenario, which is actually one of the most common reasons for referrals to the clinic, and especially in the setting of treatment with, or a pre-treatment setting with biologics or chemotherapy, is the presence of isolated core antibody. Now, this interpretation has 4 possibilities, okay? So surface antigen is negative, surface antibody is negative, meaning this patient is not really immune to the prior infection. So the 4 possibilities are either this patient has a resolved infection and yet he did not mount an antibody. Second possibility, which is 10% of the cases, is it's a false positive. Okay, so again, hepatitis B core antibody can be present in false positive. This patient can be susceptible, and you know, if you want to tease out false positive versus resolved infection, you give him a series of hepatitis B vaccination, and he should mount an antibody. Third possibility is it's a low level of chronic infection. So again, to discern this, we typically do either hepatitis B DNA in the serum. Again, if your liver tests are elevated, sometimes you will not find DNA in the serum, but when you do a liver biopsy, there could be DNA positive in the tissue. So again, low level of chronic infection, this is also called occult hepatitis B, can present with a situation where the core antibody is positive and everything else is negative. And the last scenario is this is a resolving acute infection. So again, if a patient presents with an acute flare, like in row 1, and is on his way to develop a surface antibody, but it hasn't happened. So this is the window period where the patient has isolated core, but eventually if you follow this patient, he will develop surface antibody. So when we look for the lab markers, these are typically the 2 important things that we need to ascertain. One is from a virologic standpoint. So we look for hepatitis B viral markers, so surface antigen. We will test for E antigen and E antibody to figure out what is the threshold to treat. And we also look for hepatitis B DNA to figure out if the patient has active viremia. The next important thing is we also need to assess how severe his liver disease is. So biochemical parameters like ALT, total bilirubin, and albumin, again, platelets, they will tell us the extent of liver disease in this patient. But again, we need to use fibrosis markers. You know, back in the day, yes. Someone has a question?
Hello?
Hello?
If you do have a question, feel free to write it in the chat if you're having some issues with your audio.
Okay. Well, we'll wait for the question, and certainly we will answer the question. So fibrosis markers. So liver biopsy is the invasive way to look at fibrosis, but nowadays, we have several non-invasive tests to assess for fibrosis. We can use serum biomarkers, or we can even use elastography to ascertain fibrosis in these patients. So again, if you look at any textbook of liver disease, these are the 4 classic phases of hepatitis B. The first phase is the immune tolerant phase. In this phase, you'll see that even if the patient has e antigen positive or negative to begin with, ALT levels are low, but DNA levels will be high. So again, as the word stands, the patient's immunity is tolerating a very high viral load. Okay, so this is an area of debate where we have certain criteria whether to treat or not to treat, but in majority of the cases, you would choose observation, which is an okay option. The second phase is the immune clearance phase. So this is your chronic hepatitis B patient. Most of the time, they have very high viral loads, and because of the very high viral loads, they can be e antigen positive to begin with. In this phase, you'll see that there are fluctuating levels of ALT and fluctuating levels of DNA. So again, according to the AASLD guidelines, if the ALT is over 2 times the upper limit of normal, and if the DNA is more than 20,000 in the e antigen positive scenario, this is your option to treat the patient. The next phase is the inactive carrier phase, and again, you can see here that during the natural course, a person can lose the e antigen, and because the patient develops e antibody, the ALT can be completely normal, and e antibody is now developing. So this patient can remain in this state without any major progression of liver disease. And still, this patient will be at risk for reactivation if the patient's immunity is suppressed, and during the lifelong course, even if you have a patient with inactive carrier state, you would want to make sure that the ALT and DNA remains continually suppressed and you're not seeing any flares or fluctuations. Now, what has happened in the nomenclature update is the updated nomenclature basically divides most of these into hepatitis or infection, okay? So if the ALT is elevated, you would call this as hepatitis. If the ALT is normal, you would call it as an infection. So again, these are the classic 4 old terminologies, and these are the new terminologies. And as you can see, if you have elevated liver enzymes, that's your time where you have the opportunity to treat the patient. And if you don't treat, this is a patient who can progress to fibrosis and who can develop liver cancer. Okay, so discussions. Do we have any questions from the audience?
Please remember to unmute yourselves if you have a question or some patient case you'd like to present.
He's having a
Some trouble unmuting.
Yeah.
I think that works now. Can you hear me?
Yes, we can. Thank you, Mackenzie.
Thank you. I was trying all the mute buttons and it wasn't getting it. I'm wondering if you could speak a little bit to under what conditions you would be confident that you're seeing a surface antigen, IgM core antibody, or e antigen false positive.
So surface antigen positive means this patient has chronic hepatitis B.
And I wonder about that because I've seen, for instance, transient positivity from vaccination, or I see,
Yes.
right now I have a case that we're looking at who was surface antibody positive in 2015, 2016, and surface antigen negative. And then in this year, they had one surface antibody positive, and their surface antigen positive, and their surface antibody was now negative. And then a month later, their surface antigen was negative again. And so it's just a single positive surface antigen in someone who had clearly responded to vaccination.
Right.
So I kind of wonder about false positives in that scenario.
Yeah, so this is a great question. The only thing is, if you can give us a history of, was this patient ever had positive surface antigen over 6 months?
No. No.
No.
They've had a single positive surface antigen.
They have a single
negative, positive, negative.
Okay. And what do we have? Do we have data on the core antibody?
I believe, hold on, let me pull it up. This person is, oh, I thought I had their core antibody. Let me pull it up. Sorry about that. I'm not sure off the top of my head.
Right. So actually,
I believe their core antibody negative, but I'll double check.
Right. Okay. So I think you present a very good real world scenario that, yes, you do get patients who will always come with these variable results. And some of them say, the surface antigen, some of them say surface antibody. And most of the time, again, if you look at the tables, the normal range says non-reactive, and the test result says reactive. So again, there will be a lot of confusion in interpreting the data. So that is why we want to keep this simple and strategic. So again, if you are seeing these kind of variable values and variable fluctuations in the reactivity or non-reactivity, we should follow these simple steps. So step one is you need to get all three. Okay, so a surface antigen positive by itself in the presence of core antibody negative is unlikely to be a hepatitis B infection. Okay, because core antibody is a very good sign, is a very good marker for exposure to hepatitis B. Now, like you just said, when we give hepatitis B vaccinations, we do give a component vaccine called hepatitis B surface antigen. That is what we give. So if you are a little bit enthusiastic, and if instead of waiting for a minimum 3 to 6 months post-vaccination to check for antibody, you are going to see surface antigen, which is basically what you gave to the patient. You gave a surface antigen component, and that is what you're going to pick up on the blood test. So in order to check whether the patient has mounted an antibody or not, you typically have to wait for at least 3 to 6 months in order to check for the immune response. I am also reading off a question from Anne, who said the acronyms are very confusing, which is the truth. And again, so, yeah, no, I totally get it. But again, we put it in the syllabus because that is how some of the lab tests can basically result, and that's why we used it as one of the teaching aspects of this. So anytime you see an anti, that means it's a hepatitis B antibody. Okay, so the question really asks anti-HBS means it is antibody to hepatitis B surface antigen. This is also equal to hepatitis B surface antibody. Okay, whenever you see an anti in the beginning, that's an antibody to whatever nomenclature they're using. If it is S, that's to the surface antigen. Okay, and the second question reads, how can you tell if the patient is immune to hepatitis B from vaccination? So again, I will share my slide This is slide 9. And so basically the row 3 is the one that will tell you that the patient is immune to a regular vaccination that you gave. Okay. So the only thing positive for immunity from a passive prophylaxis, which is hepatitis B vaccine, is surface antibody is positive, but the rest of the panel is negative. And the rest of the panel should only include the other 2. Okay, so all the nomenclature is really based on these 3. You will go into the other areas only if the surface antigen is positive. Otherwise, you don't need to check for any other hepatitis B serologies. Does it answer your question, Ann? You can type it in if you still have pertinent question. Okay, yes. So in the next few modules, again, feel free if any one of you wants to share your real scenarios that you see in clinic, or if you want me to, instead of talking about, you know, the didactic aspects of it, and you want me to present a few cases from my own clinic, I can do that. But again, I think this is the serologies are the ones that get people confused, and that's why we want to make sure we spend enough time on this. And module 2 will also be on hepatitis B serologies. And as Mackenzie was asking us the question about, you know, the fluctuating values. So again, we have to follow step 1, which should include those 3 in order to get a better assessment of what the patient has.
Do we have any other questions? Feel free to raise your hand or unmute yourself. All right, in that case, we're gonna launch our post-lecture polling questions. Oh, wait, we have another question from Anne.
Okay. So what's the difference between core antigen versus core? Well, hepatitis B core antigen is actually not commercially available. So even if you want to test, you cannot order a core antigen. The commercially available test is hepatitis B core antibody. There are now, there's a lot of research going on because we want to limit the duration of the treatment, and we want to eradicate hepatitis B, not just treat hepatitis B, okay? So the core antigen and quantification of surface antigen, all of these are basically still research tests. Even hepatitis B RNA, this is the silencer RNA, which also can mark the activity of hepatitis B within the liver. These are some of the tests which are investigational, okay? So the short answer to your question is there is no core antigen that you can test commercially. We have a question from Khadijat. What is occult hepatitis B infection? So that is a great question. So occult hepatitis B basically means you will not see surface antigen, because once surface antigen is positive and you see it for more than 6 months, that is chronic hep B. Okay? Occult hepatitis B means you don't see a surface antigen, but you see DNA. Okay? When does this happen? So again, this is common in areas which are highly prevalent for hepatitis B, and there are certain escape mutants for hepatitis B. Okay, so if you get an infection from this escape mutant of hepatitis B, surface antigen won't be mounted. So you will see the positive virus. So it is the presence of positive serum DNA or presence of positive tissue DNA of hepatitis B without surface antigen. That is what the definition of occult hepatitis B is. We used to see a lot of the occult hepatitis B in patients who we treated for hepatitis C, in patients who we treated for HIV. The data is all over the place. Some literature basically from Africa and Asia say that the presence of occult DNA or presence of DNA itself, along with other viruses, actually accelerates the liver disease and causes more cancer. However, a lot of the Western world data, this is data from Europe, data from North America, we see a lot of hepatitis C as well, and we did find that hepatitis B DNA does exist. But when we look for presence of accelerated liver disease, we couldn't find it. Okay, so the jury is out whether occult hepatitis B really causes clinically progressive disease. I would favor our Western world data because we are going to be practicing here in the Western world. So there's not that much role. And you shouldn't be routinely checking for occult hepatitis B DNA.
So I have a question.
Sure.
All of us healthcare workers who had our hepatitis B vaccine, 30, maybe almost 40 years ago. So you simply check does the hepatitis B surface antibody ever go down? I mean, many vaccines don't last for 10 years and 5 years as the pediatric ones.
Yeah.
Is there any reason to check these again, or just one and done, you have to, not to worry?
Yeah, so this kind of scenario gets risen typically. So I think when you ask the patient about when the patient got the hepatitis B vaccine, that should give you a clue. If most of the patients got vaccination right after birth, there is emerging literature that shows that by 4th decade or so, the antibody levels can wane off. So it is reasonable to check a surface antibody after 4th decade. But if you got hepatitis B vaccination while you're an adult, like I got my hepatitis B after entering medical school or right before. So when you get the hepatitis B vaccine, a full 3-course regimen without failing, that typically lasts lifelong. But again, after 30, 40 years, it's a simple blood test. And now we have good titers. So if you do a surface antibody titer, and surface antibody titer less than 10 means they're not protected. So it's a simple test, and probably, again, I would say 30, 40 years should be your kind of threshold to check. But more so, it is a common scenario in childhood vaccination rather than an adult vaccination.
Right. So most of us aren't rechecking them anyway as adults.
Right. Yeah.
Too many blood tests, right?
Yeah, too many blood tests.
So the other question I have is, in the infant age, why bother, except for access, but why bother administering hepatitis B then? Wait until they become sexually active or potentially prior to adolescence, potentially. What's the logic aside from they may never come back?
Well,
in high risk, or high risk because they have drug addict parents.
Right. I mean, the logic is you want to vaccinate them before they get exposed, right? So if anyone in the family could have hepatitis B, you could prevent a horizontal transmission from close contacts. Right?
Yeah, but it's the transmission usually, right?
Yeah. I mean, if you worry about the waning of the surface antibody titers, that only happens in a small majority. Typically, even a childhood vaccination would remain lifelong, okay? But again, you would check for surface antibody at 4th decade. You don't have to necessarily vaccinate them. But if surface antibody levels are quite high, you can leave them alone, and that immunity stays lifelong.
No, actually, my question is, why wouldn't we just wait until they're in 7th grade to do the hepatitis B series?
I mean, this is part of the universal vaccination program. So again,
Right.
this is to mainly, these are patients who have household members who would have hepatitis B, and the childhood vaccination would prevent that horizontal transmission.
Right. I'm sort of being the devil's advocate because we have to give, 40 vaccines with up to the age of 5.
I mean, this is not one of the mandatory vaccinations. This is recommended as part of the universal precaution. Yeah.
But we all hate to be non-compliant physicians. Right. Exactly.
Yeah.
of personality.
Yeah. We do have some other questions in the chat. Anne is asking, I know core means the patient has been exposed to hepatitis B, serum DNA. No, serum DNA does not mean core positive. Core positive is just a serology, that is core antibody. Negative surface antigen. Yes, a negative hepatitis B surface antigen means the patient doesn't have hepatitis B activity. So yes, that would be a case where the patient may have cleared the virus. iPhone from Arita. There are people who have their anti-HBV vaccine, but they do not have enough protection to anti-HBs. Why? So the question that Arita is asking is, even though you have vaccination for hepatitis B, why do not most people, or why do some people don't have the surface antibody? So hepatitis B until now, the surface antigen component, which is part of the vaccine, is given in 3 shots. It's 0, 1, and 6 months. Okay, so can you believe how many people will actually keep all these vaccinations and get their timely shots? Not many. Most people would come, again, even in my clinic, regardless of how many reminders you send them, regardless of how many times you ask them to come to the clinic. It's typically the second dose gets done 6 weeks or 3 months, you know, and the third dose will typically get, so not keeping the compliance with the protocol is one of the main reasons why they don't have surface antibody. Second is we typically see not having surface antibody if they're immunosuppressed, if they're on dialysis, or if they already have cirrhosis. Okay, so this is prior to getting kidney transplant, prior to getting on chemotherapy, you know, their immunity is already suppressed. So if in immune suppressed individuals, you'll see that happen. And that is the main reason why we want to develop more vaccinations. And like I said, there is a immunogenic vaccination that is available. It is called HEPLISAV. This is FDA approved. This is a 2-dose vaccination. And now there is enough data that is presented that is looking at a trivalent vaccination, which is even more immunogenic. And yes, serum DNA is the same as viral load. Yes, that is correct. Serum DNA is exactly the same as serum viral load. And sometimes you can also get this as PCR positive. Okay, this is polymerase chain reaction. And PCR would also mean that the patient has positive virus or positive DNA. It means exactly the same as the viral load. It's great engagement from everyone. Thank you for your interest.